Good afternoon, everyone. Good afternoon. I like a participatory crowd. Even if there's just a few of us, we're going to have a great discussion here. My name is Anita Brikman, and I am Senior Vice President of Communications and Public Affairs at the Consumer Healthcare Products Association, CHPA, and I also lead our educational foundation, which aims to educate consumers, families as a whole, on the safe use, storage, and disposal of over-the-counter medicines and dietary supplements. Our panel today is going to be talking about pain management access to support a diverse population. We're hoping for some great engagement from all of you after you hear from each of the panelists. In particular today, we're going to be looking at acetaminophen, a very common, safe, and effective pain reliever ingredient. It's in hundreds of medications. However, there are concerns about its safety profile and the potential for accidental overdose and damage to the liver. So we're going to be taking a look at this as far as the epidemiology of acetaminophen use, some learnings from outreach to college students, a campaign on Know Your Dose, knowing the appropriate dose in the Hispanic community, and we're also going to be hearing from a patient advocate. They each have about 10 minutes of presentation to give to you, and I'll introduce each of them as they come up, and then we'll have plenty of time at the end for some questions and answers. So we are joined today by Richard Knight, who is Vice President of the American Association of Kidney Patients, Marcela Gaitán, Senior Director, External Relations for the National Alliance for Hispanic Health, Ray Bullman, who is the Executive Vice President of the National Council on Patient Information and Education. It's easier to say NMQF, so I hope you don't mind if I do that, Ray. And Dr. David Kaufman, who is Professor of Epidemiology at Boston University School of Public Health. We're going to be starting with Dr. Kaufman's presentation. He is also the director of the Sloan Epidemiology Center at Boston University. He is a graduate of the Harvard School of Public Health. In recent years, he has helped lead the Sloan Survey, a U.S. population-based survey of medication use, and since 2010, he's been the co-principal investigator for a large-scale behavioral surveillance program of acetaminophen users, and he continues to be involved in other post-marketing surveillance activities around this ingredient. Dr. Kaufman.
Thank you, Anita, and thanks to the organizers for inviting me. This is a new forum for me, and I hope you will find my presentation to be of interest. So now all I have to do is figure out how to read this. Yes. So, first of all, why do we care about acetaminophen? Well, as Anita has said, it is one of the most commonly used analgesics in the world, and in fact, it's taken in any given week by as much as 20% of the U.S. adult population. So it is very commonly used. It's contained in hundreds of over-the-counter and prescription products. An important feature of this is that many of these products are taken by consumers without medical supervision, so there's potential for taking it incorrectly. Acetaminophen is generally safe when taken as directed, but overdoses, severe overdoses, can lead to potentially fatal liver damage. And there are actually tens of thousands of emergency department visits attributed to acetaminophen annually. So there are ongoing concerns about the drug, despite its common use, both from FDA and from consumer advocates. And this does affect millions of individuals who take it. That was a very quick trigger. So we have been conducting since 2010 a behavioral surveillance program of acetaminophen users. And the objectives are, first of all, to quantify acetaminophen dosing behavior, to understand current knowledge, attitudes, and behavior, and other consumer characteristics that are related to dosing. And if there are major consumer initiatives, they can be assessed to see whether things have changed following these interventions. Data collection, there are two main parts that I'll be telling you about. First, the acetaminophen pattern study conducted in August of 2010, and a low education, low literacy study that we conducted in I got to look at my slide, October, December 2011. We have been also continuing the surveillance since 2011, and this is sponsored by McNeil Consumer Healthcare. So principally, this is web-based data collection from individuals who are members of internet panels. The key feature is a 7-day diary, which is completed daily. And an important facet of that is that acetaminophen products are identified by prompting with product lists, which means that the users do not need to know that their products contain acetaminophen. And as I'll be showing you, many of them don't. There's also at the end an exit survey where knowledge of ingredients and label directions, attitudes toward medication use, label reading behavior, and medical history and demographics are obtained. Our focus is on exceeding 4 grams in a day. That is the maximum recommended labeled dose. And I would note that although one can consider taking more than 4 grams to be an overdose, there's actually a large margin of safety. And the vast majority of individuals who take a little bit more than 4 grams do not get into trouble. We conducted analyses of the users, what we call person-level analyses, looking at what proportion of users exceed 4 grams and who are the individuals who exceed 4 grams, and then day-level analyses to understand the patterns of use that lead to this overdose level of acetaminophen. So first, how often is 4 grams exceeded, and who are the people who do that? In this pattern study, there were about 3,600 users. 4.5% of them exceeded 4 grams on at least one of the 7 diary days. A much smaller proportion exceeded 8 grams, so the majority of them didn't take that much over 4 grams. And I would also note that in the ongoing surveillance, the prevalence, which has been conducted year-round rather than a single month, the rate is a little higher. It's 6.3%. This slide shows the prevalence according to whites versus other race ethnic groups. And the important thing is that although the bar is a little bit higher for non-whites, it's actually statistically indistinguishable. So these are really not different. Unfortunately, we lacked enough data to really look at individual racial or ethnic groups other than whites. But we did look. The results were very unstable, but there were not any important differences. So this is a little disappointing, I think, particularly in this context, but it's unfortunately what we have. Now, the health literacy study that I mentioned shows a very strong relationship between individuals of very low literacy and going over 4 grams. The prevalence is 10% in those with very low literacy compared to around 3% in those with low or adequate literacy. So it's quite different. I promised to say something about knowledge. This slide shows the individuals divided according to whether or not they knew that all the products that they took contain acetaminophen. So I want to point out 2 things. One is those who knew this about all of their products had a much lower prevalence of exceeding 4 grams than those who had at least one drug where they didn't know. So it's 6% versus 3%. But the other point that's important is that almost half of the people did not know that all the products that they took contained acetaminophen. So the actual level of knowledge was quite poor. This slide shows most of the factors that were associated. So one of the things that we looked at were attitudes. Choose my dose is an attitude that basically states that directions or guidelines and I can make my own decisions. People who had those attitudes were more likely to go over 4 grams. On the other hand, people who had the attitude that you can start with the lowest dose and only take more if you really need it tended to have lower rates of exceeding 4 grams. Knowledge, I've already told you, if you have good knowledge of ingredients, you were less likely. Also, if you knew the maximum amount to take at one time or in 24 hours, the rate of going over 4 grams was lower. Chronic or ongoing pain, not surprisingly, was associated with exceeding 4 grams more often. And those who had good physical status as measured by the SF-12, which is a well-known scale, were less likely to go over 4 grams. And finally, individuals who had a lot of healthcare visits were more likely to go over 4 grams. And we'll come back and sort of summarize what we conclude. But now just quickly, I want to talk about how is 4 grams exceeded, looking at within-day dosing patterns. So there were about 14,000 usage days, and the median dose was 1 gram. That's the equivalent of 2 extra-strength Tylenol. So that's sort of the typical, if you will, dose. 4 grams was exceeded on 3.1% of the days, and the median dose on those days was 5.5 grams. So it's still not a lot higher, although there were some individuals who had much higher doses. So how do people get to go over 4 grams? Well, 92% of them had at least one other label deviation, which is to say they contravened the label recommendations in some way. Concomitant use means taking a second acetaminophen product within the dosing interval of the first. Redosing too soon is taking the same product too soon, and too much at one time is too much in one dosing occasion. But very few individuals didn't have at least one of those. We also showed that people who take multiple acetaminophen product types are more likely to go over. And you can see a much higher prevalence on days when over-the-counter and prescription products were taken on the same day, compared to days on which only OTC products or only prescription products were taken. And among those who took over-the-counter products, if they took a single ingredient in a combination product, they were more likely also to go over 4 grams. So multiple product types is definitely a factor. So I have only 2 more slides of results. The key points, how can we summarize our results? So first, how often is 4 grams exceeded and by whom? It's approximately 5 to 6% of acetaminophen users. It's linked to poor knowledge of medication ingredients and directions, associated with attitudes of choosing your own dose and of not trying the lowest dose first. Ongoing and chronic pain and disability lead to going over 4 grams, multiple medical visits, daily smoking, which I didn't show, and also very low health literacy are risk factors for exceeding 4 grams. There were minimal differences according to race and ethnicity, but the data were insufficient to permit a detailed evaluation of that. In terms of how 4 grams is exceeded, it's almost always by deviating from label directions for one-time dose, dosing interval, or avoidance of concomitant use, and by use of multiple medication types. So where does this leave us? A few suggestions for mitigation of this situation. First, to undertake widespread, and I really want to emphasize widespread because there needs to be a huge penetration to really get somewhere, of consumer education and initiatives that focus on improving knowledge of ingredients and label directions. And in the course of that, and I think that the subsequent speakers will tell us a little bit about how the needs of individual communities, what they might be, and it's important to address those needs. An icon that could be on all acetaminophen products to help identify it would be very helpful. And finally, to engage healthcare providers to focus their patients on responsible use of acetaminophen would be very helpful. So I'd like to acknowledge my colleagues. This was a large team in doing this research. They're listed on the slide. And finally, I'd like to thank you all for listening. Thank you.
Is this on now? Oh, good. A little technically challenged here this afternoon. Our next speaker is Mr. Ray Bullman. He is the Executive Vice President of the National Council on Patient Information and Education. As I said earlier, NMQF. In particular, we are honored to work with Mr. Bullman on their work in promoting safe use of acetaminophen. They've convened multiple stakeholder forums on OTC safe use, including taking OTC literacy beyond the classroom, advancing our understanding of the safe use of acetaminophen and other projects. And most recently, NMQF partnered with the Boy Scouts of America to develop and launch the Scout Strong Be Med Wise program so that they could actually earn a patch for understanding safe use of OTC medicines. And I know, Ray, you're going to give us some insights on, in particular, learnings NMQF has had on talking to college students and the different populations and addressing safe medicine use among those.
Yes, thank you. Good afternoon, everyone. Let me see if I can, there we go. I'm pleased to be here this afternoon. I apologize for that, it kind of crept down on me. I'm pleased to be here. I'm going to shift a little bit. Our first presenter talked about about epidemiology, and I want to provide some insights and some learnings that our group, NMQF, National Council on Patient Information Education, has learned from being privileged to have done some work through some grant support over the past 3 years with the Substance Abuse and Mental Health Services Administration. Although focused on preventing prescription drug abuse awareness, focusing on preventing prescription drug abuse, and talking about awareness and referral for treatment and recovery services, particularly from a campus-oriented perspective, I think the learnings are very relevant, and they speak. I hope at the end they speak to the fact that what we need to do is we need to listen and learn, and that's the takeaway that I want to, I'm sure it's nothing new for you, but I want to reinforce it from our organizational perspective because it has been a significant learning for us. Very quickly about NMQF, we're a 501c3 nonprofit group. We're located out in Rockville, Maryland, just a stone throws away. We were organized back in 1982, so we're on our 35th anniversary year this year. Our singular mission is to focus on stimulating and improving communication to promote safe and appropriate medicine use among the general public and healthcare professionals. This is just a smorgasbord, as it were, of some of our educational programs. Anita mentioned our Scout Strong Be Med Wise program. That's 4 online modules for Boy Scouts, of which there are about 2.7 million, where they can learn about safe and appropriate use of over-the-counter medicines and earn a Be Med Wise patch at the same time after they indicate their knowledge on the subject. So you see other programs, Recovery Opens Doors, medication use safety training for seniors. So we have a very broad and diverse portfolio of educational materials that are principally focused on creating awareness and knowledge and changing attitudes and behavior that is very much age-oriented. For example, there are 3 modules that NMQF has developed on a safe and appropriate use of acetaminophen. We've done this as part of our contribution to being part of the Acetaminophen Awareness Coalition, of which a number of the groups here are involved as well. But as you see, we have a toolkit for college students, we have a toolkit for adult teen influencers, and one for older adults. Each of those populations, of course, has their own informational interests and informational needs, educational interests and needs, and their own patterns, for example, of medication use, whether it's over-the-counter, whether it's over-the-counter medications or prescription medications, for example. Very different and distinct. But what I want to focus on for just the next couple of slides, and perhaps when we get into a discussion, is the opportunity I mentioned that with SAMHSA, we received a grant that has enabled us for the past 3 years to go out onto college campuses across the United States and conduct what we've called campus dialogues, listen and learn sessions. And very specifically, we were invited and challenged by SAMHSA to focus these campus dialogues to bring together students of color on campuses where either majority or significant or almost in the entirety where students of color are students at those campuses. You can see that we conduct campus dialogues where we convened African American, Hispanic, Latina, American Indian, Native Alaskan, Asian American, and Pacific Islander students. And that also includes bringing together or convening faculty and staff as well, and oftentimes people from the surrounding community to try and get a town and gown perspective. Much of the focus has been on gaining a perspective of historical, familial, and cultural influencers that have put young people at risk or may put young people at risk or protect them from prescription or other forms of medication misuse or abuse. Students, faculty, and staff have shared short and long-term recommendations on how to make the interventions relevant, what services are critical, what's missing, and lessons on how to better engage with students. The campus dialogues have resulted in creation of specific and broad-based recommendations and strategies ranging from how to deal with study drugs, opioids, and other drugs of misuse to exploration and implementation of campus and culturally based prevention strategies designed to provide alternatives to drug and alcohol abuse. And some of the strategies you can see I have bulleted out here. I won't read them in their entirety, but one is, for example, incorporating prescription drug abuse prevention into existing training and training staff and faculty to communicate more effectively. We heard that over and over, that students, when they sit down with faculty and staff, they have great discussions about the topics in their classrooms, but it really needs to be from a broader perspective in terms of that engagement. Another learning was educating young people about the risks and benefits of prescription medications, as well as what I would call our prescription medicine stewardship, which means proper storage, disposal, and no sharing practices, particularly on campuses, and identifying stressors associated with trying to achieve academic excellence and their connection with prescription drug abuse. In 2004, we convened our first Listen and Learn campus dialogue here in Washington, D.C. on the campus of Howard University. We did that by holding a precursor meeting with 20 students who helped us plan the dialogue, and we then hired students of color in advanced training to help us by being the facilitators for the dialogues with both faculty, students, and staff as well. You see this. We didn't have any travel money to go to the campuses, so we invited campuses from about 125 miles around the radius to come to the Howard University, and we had a great 2 days at that campus dialogue. The HBCU participants identified and agreed that there were 6 influencers, which they ended up calling very creatively a cycle of influence, that negatively impacts students' perceptions and abilities to cope with campus life, and that students' response to these influencers can lead to misuse and abuse of prescription medicines, economic incentives, availability or overprescribing, misinformation, peer pressure, traditional stress, and racial disparity. The HBCU dialogue participants agreed that they wanted to bring prescription drug abuse on their campus and in their local community out of the shadows by creating a connection, by creating a culture of connection, helping to ensure that a system of help was in place before crisis hits. They understood that student engagement and creating support systems, even before students became freshmen at school, are key. And they identified these 6 areas of change as you see on the slide. Number 6 was interesting, exploiting conditions to viralize change. They talked about all the pressures, and, for example, that our smartphones bring to us or create for us. For example, they came up with the idea of an unplugged day, where the campus is basically quiet for a day, except for talking. And I thought that was pretty innovative. The HBCU participants also identified 6 actions or prototypes of change that campuses can immediately integrate or do over time that focus on norms, institutional bias, traditional stress, lack of resources, and particularly social media. We heard that over and over, the need to engage with and use social media for good, as it were. I just want to give you a few sharings from a second campus dialogue that we did in Lawrence, Kansas with the Haskell Indian Nation University. We met here in DC with about 20 Native American Alaska Native students before we developed the campus dialogue at Haskell Indian Nation University. We created a campus planning team that included students of each of the 4 years of the four-year college. And the faculty and staff and students recommended both immediate and near future recommendations within strategies to focused on providing more and extended services. And you see some of the immediate recommendations from the students, and it's a very different perspective than from the HBCU student perspective, but things like making sure that culturally specific activities are part of everyday life on campus, that are part of the process of education at Haskell Indian Nation University. And they gave some recommendations or suggestions, for example. Then looking at some of the near future ones, the students shared with us that, for example, they have a great gymnasium and a student area, but those basically are closed down at 5 p.m. Weekday and weekend because it's part of a federal system. And so they said, this is, it's like there but not there. So, just things like that in terms of creative use of time and addressing boredom and things like that. But as importantly, integrating behavioral health in the Indian Health Service clinics and engage with the Indian Health Pharmacy staff to teach classes on drug abuse education. Less than 2 blocks or so from the campus of Haskell Indian Nation University is the University of Kansas School of Pharmacy. School of Pharmacy students have really never had the opportunity, and Haskell students have never had the opportunity to engage. So that's part of what this dialogue was about, was trying to recognize and bring together resources that are there at your fingertip. This is a slide that just simply, we asked students from the HBCU dialogue to give us in one word the takeaway from the dialogue itself. And this is not edited, these are all the responses we got, and you'll see that they're very positive and they're very proactive and they're looking forward. We're excited about that. And I guess the end takeaway is that pain management access issues and the challenges of education about safe and appropriate medicine use, even though it's could be OTC medicines, are distinct among and across diverse populations and influenced by family, history, and culture. Nick Pye has learned we don't know what we don't know. We can surmise, we think we know, or we surmise what we don't know. And then if you look at the definition of surmise, suppose that something is true without having evidence to confirm it. So what we really know we need to do, and we encourage everyone to do, is listen and learn. Thank you.
Thank you very much, Ray. As the mother of 3 teenagers, I'm all for an unplugged day. Can we make that like a national holiday of no cell phones? Marcela Gaitán is our next speaker. She is Senior Director for External Relations at the National Alliance for Hispanic Health in Washington, D.C. She serves as project director for a portfolio of initiatives, too many to list, but they do include the FDA Hispanic Outreach Initiative to improve access for Hispanic consumers to FDA information and health messages, and specifically to enhance FDA outreach efforts about risk and emergency communications about the appropriate use of FDA-regulated products, which, as we know, acetaminophen is one. Marcela?
Thank you. Thank you very much for being here. And as Anita mentioned, the National Alliance for Hispanic Health, we're a public health organization, and we work with a network of community-based organizations around the country. Let's see. Okay, oops. And we are located in Washington, D.C. We have member organizations, and our mission is to improve the health of Hispanic communities and work with others to secure health for all. We've been in functioning since 1973. We are dedicated to community-based solutions, and we do not receive funds from alcohol or tobacco companies. Now, for the Know Your Dose campaign, as Ray mentioned, this group is actually managed by a coalition of the Acetaminophen Awareness Coalition, and the Alliance joined the group to work with the Consumer Healthcare Products Association to support the development of the campaign to target Hispanic communities. The coalition is a group of, that includes clinicians, consumer organizations, and also health organizations. Now, for the campaign in Hispanic communities, the goal was to support the CHPA in developing the framework for the Know Your Dose campaign to reach Hispanic communities, but also develop culturally proficient and language-appropriate materials to promote the safe use of acetaminophen specifically. The program conducted an environmental scan of the literature information that related to Hispanics in acetaminophen to inform the development of the protocol that it was developed to do the community panel discussions at the local level. The sessions were conducted in 3 cities, and then the idea was to gather the opinions, not only from the consumers, but also from the providers that actually serve Hispanic communities in relation to acetaminophen and its use. There were 4 areas that we addressed. It was the general use of the medicines. We included prescription and also over-the-counter knowledge, attitudes, and behaviors, the communication platforms to reach Hispanics, and also we had some resources that we wanted to test with the community, and also we wanted their input on developing messages. The methodology, like I mentioned earlier, we selected 3 sites. We did San Diego, San Antonio, and Miami because we wanted to make sure there was an inclusion of all different Hispanic subgroups. So we wanted to have people that were Cuban Americans, we wanted to have Puerto Ricans, we wanted to have Central and South Americans, and also Mexican Americans. We recruited males and females, but as usually is the case, we got more females that participated in the sessions. And then the ages range between 18 to 70 years of age. And the educational attainment included people who had finished up to like 4th grade, but also there were people who had finished college. The majority of the participants spoke both languages at home, were about 70% English and Spanish. Now, in terms of the providers, the group of providers that were also part of the community discussions at the local level, there were about 53% that were non-Hispanic, but 80% of them actually spoke Spanish. And the participants included physicians, family practitioners, internists, pediatricians, and there were also other healthcare providers like pharmacists, nurses, PAs, and health educators, and also midwives who participated in the sessions as well. Now, in terms of some of the findings, it was interesting to hear the results from what these sessions brought. Participants some of the responses included that they use both over-the-counter and also prescription medicines, but they don't really know if they contain acetaminophen. And if they do know that they contain it, is because the physician or the health provider indicated to them. They mentioned that they take sometimes 2 medications with acetaminophen at the same time. They also mentioned that they take medications with alcohol. And then they're not aware of the names, other names for acetaminophen, and they tend not to follow some of the dosage instructions, and they take more than is actually recommended. Other findings, for example, the participants indicated that they don't read labels all the time, and they take the medicines as often as they need, and I guess that goes with David and Ray mentioned in their talks as well. Although they were concerned about overdosing and the effects of these medicines sometimes they have in the organs, they were confused about which organs. Some people thought the liver or the kidneys or maybe the stomach, and they thought if it affected the stomach, maybe they will get a stomach pain. They say they prefer the brand names. They know the medicines with the brand names. They don't like to hear the kind of like chemical names or more like the drug names. And there was confusion. There was a confusion about what is the ingredients of the medicines as well. And then they recognize, like I mentioned before, they recognize the brand names. And then there is confusion about acetaminophen and ibuprofen. Okay, now we wanted to get some of their input in terms of developing messages that will be effective in the community. And this usually is very common when we do different focus groups for different programs. They always tell us develop simple, short messages, and they also need to be developed in Spanish. And even though when we look at the Hispanic household, they usually see different generations. So you have, for example, the grandparents who may only speak Spanish, but then you have the children who were born in the U.S. who are bilingual, or some of them actually speak mostly English. They might understand Spanish. So it's always advisable to create written information that is actually in both English and Spanish. And we see many times also that the children help the grandparents or even the parents when it comes down to translate some of the information, or even help them, the parents, to understand the information when it comes down to brochures or written materials. And then some of the things that they suggested, for example, they would always follow the label, know if your medication contains acetaminophen, and never take two medicines that contain acetaminophen at the same time. In terms of the communications platform, this one we wanted to find out what will the best ways to reach Hispanics, with what type of media, what type of communication channels that will be the best. And then they suggested digital and social media, and they use actually digital and social media on a regular basis. But they also talk about TV, radio, and another way that people seem to be very receptive is by word of mouth, and they talk about having community agencies and promotoras program work with them to give some sessions on this type of topics. They like vivid color and pictures and large print for the brochures, for any type of written material, but it has to be simple and short. And they also indicated that they trust their healthcare providers, not only as a source of health information, but also as messengers. Okay. Other areas that we got some feedback were the campaign should include a mix of not only written material, but also include social media messages, TV, radio, again, and again, work maybe some sessions with promotoras at the local level. And one thing that they mentioned is that some of the specific efforts should go to teach Hispanics to read drug labels. That way they can learn where the acetaminophen is included. And then another thing that they mentioned that was kind of interesting, they use entertainment education, and that means perhaps like some of the soap operas may include some embedded messages about health. People watch a lot of soap operas, so they might be able to get the message from that. And then also, if you provide written materials to the community, include a phone number or a helpline number where people can call for more information. Now, from the perspective of the providers, in general, they all wanted to be involved in this type of campaigns, and they wanted to become engaged. And they suggested, for example, emphasize to consumers that they should ask their providers about acetaminophen and the ingredients in their medicines. They have to, the materials, again, according to the providers, they should also be short, simple, with vivid colors and to the point. And then this type of material should be bilingual in English and Spanish. They should be on display at the pharmacies, at the clinics. And then one interesting thing, especially this is a case for cities who are near the border, the physicians recommended that if possible, always remind patients to bring their medicines to the doctor, especially because in the border cities, a lot of patients sometimes cross the border, go back and forth, and they bring medicines, and they take medicines even if they're not prescribed by the physician in the U.S. So for them, it's always important to know where the patients are taken. That was one of the interesting comments that we got from the providers, especially that was, I believe, San Diego, which is a border city. So we, as part of this campaign, we developed some cards, we developed some postcards that we mailed to our members, and we also developed an animated video that is found in our YouTube channel, and it has gotten a lot of hits. And it's a very simple thing. We did it at the office. It's not like a fancy thing, but it was quite effective. And if you have any questions, I'll be happy to answer questions. And I brought some sample materials in case somebody is interested. Thank you.
Thank you so much. And Richard Wright, Vice President of the American Association of Kidney Patients and a patient advocate himself.
Good afternoon, everyone. Well, as we bring it to a close here, I will be brief. I'm going to talk a little bit different. I'm going to talk about pain management, access to support a diverse population from a patient's perspective, because I, in fact, am a patient. I'm a transplant patient. I spent about 2.5 years on dialysis, and I had a transplant roughly 10 years ago, in 2006, a little bit over 10 years ago. And one of the things that you learn as a patient is that you have to know your meds, you have to know your body. And I want to add a little bit more context to this. As she introduced me, I'm with the American Association of Kidney Patients. And I don't know how many patients we have in here. How many patients do we have in here? Of course, it's a trick question. Of course, you know, we all are patients at some point. And I'm certain that many of you know individuals as I go through this that will probably touch upon friends and relatives that you have. Context, a little bit about the American Association of Kidney Patients. We were founded in 1969, and we are now the oldest and largest, and I emphasize, independent kidney patient advocacy group. It was our organization back in 1972 that rolled a patient out on the floor of the House Ways and Means Committee and continued to push for legislation to support dialysis, and that subsequently bill was signed by President Nixon and became law and is now what we know as the End-Stage Renal Disease Program, administered by CMS, Center for Medicare and Medicaid, and it remains the only disease-specific U.S. entitlement program. Now, our purpose as an organization is to educate. We educate patients, caregivers. We educate a lot of the medical professions, want them to look at things from another perspective, from a patient's perspective, which is very different generally from the health provider's perspective. And also we advocate, and more recently, we have had to become involved in defining actually what patient engagement is. So the importance of this, as we do our work, we collaborate with a lot of organizations. We're a small organization. We have a very, very large reach. I just found out that we have been voted on to the board of NMQF, so we'll be doing more work with them. One of the other organizations that we do work with in a collaboration perspective is Protecting Access to Pain Relief Coalition. And that was how we joined together to focus on the area of acetaminophen and pain medication. And we serve on the steering committee, so we're very much involved in that. But what does that really mean? We've talked a lot about the impact of knowing our medication, but what is that impact of the pain? Again, to give you a little bit of context, roughly 25% of Americans 18 to 59 are in daily pain. 110 million Americans live in daily pain. 81% mostly use over-the-counter pain relief, ages 18 to 59, and 70% of Americans 60 plus. That's a very large number. Now I can see. We often make reference to acetaminophen. It's one of the most widely used medications, most important medications in the United States. Strong patient need for it. And it's found in over 500 different prescriptions in different forms over-the-counter medicines. And we often talk about safety issues and the need to monitor it to make certain that we don't have overuses. But one of the other things that we must look at, if you're not using acetaminophen, for example, you could be using non-steroidal anti-inflammatory drugs, NSAIDs, which, and if you watch the commercials on TV, the ibuprofen-based medication, Advocacy and all that, well, for patients such as myself, that's deadly to me. So not only do we need to understand that we need to limit our dosage on something like the acetaminophen, but we also need to understand that there's a whole class of medications that we shouldn't mess with at all. And particularly for anyone that has had a transplant. And where is the connection between that and the pain relief medicine? Just a few statistics with respect to African Americans. We're 3 times more likely than Caucasians to develop kidney failure, and up to 10 times as likely to develop kidney failure due to hypertension. What are some of the main causes for kidney failure? Diabetes, number 1. Hypertension, obesity. All of these are factors, lifestyle factors. So education is very important, and there's a direct correlation between if you, in fact, don't control those particular factors, kidney failure is something that can happen. African Americans make up 13% of the population, but represent 32% of those with kidney failure in the United States. If you talk about the areas where people live, socioeconomic status, African Americans are 57% less likely to get on a list for a transplant than their Caucasian counterparts. So there's some significant numbers that we have to keep in mind as we talk about the impact of this. Now, I know we've talked about overdosage and things of that nature. Very, very important for us to understand and take that into consideration. But again, back to the education part. We spend a lot of time educating the patients and caregivers so that they understand the impact of this. As we visit our doctors, obviously I have a primary care physician. I also have a nephrologist that deals with my renal issues. And when you have a transplant, some of the medication that you take makes you susceptible to certain things, like diabetes and gout, which can be very painful. And my primary care physician prescribed me with one of the NSAID-based medications. I said, Doc, I can't take that. Oh, fine, it won't hurt you. Of course it will, Doc. It's not good for me. I know that because I've read, and when I was in the hospital, my nurses grilled me on my medication. So again, we hear these concepts and we hear the words, but when it becomes a matter of life or death, I think it has a little bit different meaning to you. Was in a hospital on one occasion, and the nurse asked me to take my medication. I said, well, what is it? And she told me, I said, that's the wrong dosage. No, it's not. Well, you're just a patient. You don't know. I said, okay. Well, you need to bring your boss and your boss's boss, because I'm not taking that medication. Had I taken that medication for the length of time that she was going to give it to me, just over 4 days, my body would have rejected my organ, my transplant. And she was adamant about it. So again, very important for us to understand as patients, and as all of us out here who ultimately may become patients, may have older individuals in your life. And as a matter of fact, the numbers are increasing that many more folks who are much younger than what the statistics show are having issues. Diabetes, hypertension, and obesity are certainly rampant within the African American community. Right here in the DC metropolitan, we have roughly 1.2 million individuals, 20 million throughout the country, that have been diagnosed with some phase of CKD. And because of the discomfort and pain that is associated with that, we would definitely go to the drugstore, CVS, and I'm not pushing any particular type of medication, but when you see all the commercials, you think that you have quite a few choices. And I'm limited. There's only about 3 over-the-counter medications that I care to take, and somebody's always advising me to take something new, but I kind of go with what's tried and true and don't want to take the chance. And again, I'm going to make a plea, and I think my colleagues did a great job up here, laying the backdrop and different programs that are in place to help us understand, and they're doing a lot of educating. But I also like for folks to make the offer to you that you can visit our website at akp.org, and we have much information up there. I've just recently found out that a lot of nursing schools go to our website and use our educational material because it's more patient-oriented. And I think the key is that we have to be able to communicate with a patient. One of the last times, I haven't been to the hospital since 2011, so I'm not one of those sickly individuals, and I certainly take pride in that. But by the same token, I do realize that I'm very, very fortunate and that I don't have a lot of the issues that some of my colleagues have, which is why I spend the time doing what I can do, because I have the physical ability to do that. But the point that I'm making is that I was listening to a nurse give this gentleman his discharge notes. And I'm sitting there saying, and he doesn't understand a word that she's saying, and as soon as he gets out here, he's going to go home and he's going to eat that fried food, blow his blood pressure up, and he'll probably be back in here in another month or so. So I think that it's incumbent upon all of us to really be on top of this. The numbers, on my way over here, I was just on a call talking about patient-centered outcome measures. And all the docs are talking about statistics and things of that nature. And, this group of patients on would say, well, what about quality issues? Well, we have to have things that we can measure and that are valid. So part of the disconnect is that we have to do a better job of communicating in a manner that makes sense to someone. Because you can talk to them and give them all the information that you want, but if they don't receive the message, then it's not going to be effective. So this is a much needed session this afternoon, and I hope that everyone walks away with some information that you can hold on to and that you can pass on, because that's very important. This is something that we can greatly improve by being better educated, going on these various websites and getting the information that you need, because you've got a lot of information shared this afternoon and information overload is rampant in this society. But pick a couple of websites, and you've been given some good ones where you can just go out there and get you some basic information. So I'll stop there and turn it back over to Anita. And thank you very much. I appreciate the opportunity to be here.
We got started a little bit late, so I want to make sure we do have time for questions. Does anyone have a question for our panelists? Yes. Want to come up to the microphone? And again, thank you all. Such great perspectives on kind of the epidemiology, community outreach, and the patient perspective. So it's wonderful.
What's one thing that the Black church can do to help educate the community around the prescription abuse and misuse? I'm from Kansas City, and we do a lay health worker training in the Black church around how to communicate your pain to your doctor, but what are some things that the faith-based communities can do to address some of these issues?
You got it. It should be on.
Hello. Okay. Well, certainly one of the things that you can do is, what gets measured gets done. You can start out with basic information like, blood pressure, letting people know what their blood pressure is. Some places give out little cards that they can take to their primary care physicians and ask certain questions. And one of the big challenges is, and again, I like to put people in a position where they can avoid taking the medications. And that's why I'm saying these preventive things. But in the event that you do have to take the medications, you certainly want to understand the impact. And I think if you create that health environment within the church where you give out the information, you provide the blood pressure, there's things like creatinine level, and with diabetes, there's a whole nother set of metrics that you can follow. I think that you can educate the people, and particularly the men. You know how men are. They want to wait till the last minute and make certain that they go and get that checkup and get the results and follow up. But I mean, that's a real good thing that you're doing in the community.
And in relation to acetaminophen, we have knowyourdose.org. We have all of our materials that are downloadable and can be ordered that are very specific to acetaminophen safety, and those brochures and other materials can be downloaded and shared in a community setting.
Hi, thank you. My name is Joy Harrington. I'm with a medical education company. And so I had a question, something that you had touched on in terms of knowing what works for you and taking medication that works for you. But how might patients, which should be us, educate physicians or be able to educate clinicians on that kind of information where the clinician, being a physician or nurse practitioner, a provider, has all the scientific information, they know what you're supposed to prescribe. They also have laws that they may have to adhere to, especially when you're talking about opioids and Schedule II drugs. But what they may prescribe or require may not be what works for that patient. My husband has sickle cell disease. He kind of takes his morphine the way it works for him, that I'm sure his providers don't want him to take it that way. So how do we create kind of forums, I guess, for that kind of conversation between the providers and the patient, so that the providers are not kind of just hammering away at the patient on what they're supposed to do and not listening to the patient saying, but that doesn't work for me?
I think on the OTC level, can we talk a little bit about education even on the basics with ibuprofen, acetaminophen, some of the confusion we've talked about? Right now, in particular case of OTCs, acetaminophen is highlighted on the level, but there was a discussion about an icon with something like that, as well as information to healthcare providers to make this a frontline conversation, as well as here's your OTC options, here's your prescription. I know doctors' time is limited, so how do we encourage that?
One of the things we have on our Talk About RX website, talkaboutrx.org website, a downloadable piece that says, getting ready for your doctor's visit, make notes and take notes. And it also says, take a spouse, take a partner, take a friend, and take pencils, and let them, and actually, some people even take a tape recorder and they say, I hope it's okay, but I'm going to tape this discussion so that I can listen to it at home. And that includes questions to ask about why I think I'm here, what I'm experiencing, what medicines I'm taking, and what questions to ask if a medication is prescribed or recommended, in terms of not just the benefits, but the potential risks as well.
Yeah, I'm Dr. Berthel Archie, and I could have been out of the room when you shared this, but will you share your stats with me in reference to how prevalent is the problem in reference to persons consuming more than 4 grams of acetaminophen?
Yes.
Yes.
So
I'm looking for the background.
Well, all right.
information.
So the average is about 6%. About 6% of adults who are taking acetaminophen seem to take more than 4 grams at least once in a 1 week period.
And these are frequent acetaminophen users who are using it for chronic
These
pain?
are generally regular. Frequent is maybe a strong word, but they I would say in the week, the typical number of days that they are taking acetaminophen is maybe 2 or 3 for most of them. Some of them take it every day.
And how does that parlay with morbidity and mortality? Do you
Well,
have
that's a very good question, and I think that one of the real conundrums is we can measure how much people are taking. The question, though, is how much do you need to take to really damage your liver? And I would say that's not known. It is generally considered that if you take less than 8 grams, it's probably safe, although undoubtedly there are a few people who get into trouble at that level. But there isn't really a level that's sort of stated, if you take more than this, you're going to damage your liver. Does that help?
Yes, very much so. Thank you.
Good afternoon. Yes, I'm Jamila Rashid. I'm the executive director of a pipeline program for training health professionals. We actually start at the kindergarten level all the way up through health profession schools. And I'm very interested in what you were just talking about. It's actually the way that I deal with my own health issues and interactions with health professionals, especially what you were talking about a few minutes ago. And I'm just thinking about, it made me think about what else could my program be doing to educate the students who may not be getting this same message through the courses that they're taking as part of their health professions degree. So that's really what I was interested in hearing, if you had any thoughts about that.
Well, I think that we are very much committed with the Educational Foundation and our partners in the Acetaminophen Awareness Coalition to really look at messages that resonate throughout different ages, and in particular in that preteen area where, in particular when it comes to OTC medicines, where kids may start to self-treat in some ways. We of course never advise that. We advise them to talk to their parents, but that has been a focus, I know, by Johnson & Johnson as well, to look at that age group and how to educate on medication safety in that age group. And I know there are quite a few educational materials around that at that different age. Also, know your dose, and this idea that this acetaminophen, that's that one ingredient you should look for. It's a very straightforward message, and the earlier we can get young people to understand that they have to look for that and not double up on it is very important. But as Richard said, ibuprofen and NSAIDs aren't without their risks at all. I think what we try to do is advocate that people use the least amount possible for the shortest duration of time, but also know their own risk profiles. So I think that given the different websites that were mentioned, there are different resources that could be helpful and certainly can be utilized and adapted. I think the sensitivity of knowing your audience and who those kids are and making sure it comes across as peer-to-peer, I think is very helpful. Any other thoughts on that?
Just a few, and that is with health training of healthcare professional students. When we did some of the campus dialogues, we did several out at Montgomery College and one in Tacoma Park, where there are a lot of healthcare professional students, and encouraging organizing on campus and for community-based health fairs, and getting the health professional students actually out in front and talking with consumers and using the kinds of resources like the Know Your Dose materials are great. Pharmacy students all across the country are involved with the Know Your Dose campaign, and now they've brought in medical students and nursing students, but the other healthcare professional students are really, that same opportunity and resources are available.
I'm glad you mentioned about working with other healthcare professionals, because when we work with community-based organizations, many of the patients that go to these agencies, the first person they'll see might be a nurse, and they might see the nurse throughout the whole time before they actually get to see a physician. Sometimes they actually even talk to the promotoras de salud, who are great messengers for the community. So yeah, so getting them the materials, the information that is out there so they can distribute it in the community is great, and especially getting the other health professionals involved is a really good idea as well. I mean, it's very important.
Hello, my name is Charlene Harada Womana, and I'm representing my nursing organization. It's called Black Nurses Rock, and I'm the president of the Baltimore chapter. Next month, May the 17th, is National Blood Pressure Day. So in Baltimore, we're collaborating with the Heart and Stroke Association, and we're going to do pop-up blood pressures in the vulnerable communities. So a part of why I came up is I want to know what businesses are doing in different pharmaceuticals when it comes to giving certain nonprofit organizations funding to help the community understand some of the literature and some of the information for nursing. Because what I found in my city is when they see the nurses in their city on their pamphlets, they tend to come to the hospital because they know we're in the community. Instead of them stopping us on the street, they've been coming to the clinics. Now that our local hospitals have placed the nurses that's in the hospitals in the community brochures, now it's bringing more of the community together and wanting to come and find out about their health care.
That seems like an excellent strategy, and what we've talked about really delving into the community, listening and learning and seeing what works. In the case of private support, I can say that the major manufacturers of OTC medicines do support this kind of educational work by their donations to the Know Your Dose campaign and our educational foundation. There is a strong industry commitment to try to have everything from social media to mommy bloggers to events where we can share our messages. We also present to nurse practitioners and other health groups. And as Ray mentioned, the pharmacists are on board. We've been working with family physicians. And so there are definitely industry efforts to try to support outreach. I also want to just bring up too, one thing for you, Richard. You know, we know acetaminophen has been a focus of the FDA. 2009, they identified where there could be problematic overuse or, accidental overuse and exposures. And so there has been discussions. There was, in fact, some limits placed on prescription strength daily dose, and there's been discussions and some concern among some patient groups that there could be restrictions on OTC. And as you said, you're part of a patient population that really has to stick to acetaminophen. There aren't a lot of choices. How did the patient voice get communicated to FDA in their, you were talking about the forum, the coalition that you're part of on protecting pain medicine access. What strategies did you use to make sure the patient voice was heard by regulators in maintaining access to pain medication?
Thank you for asking the question. One of the things that our organization tends to do is, again, we collaborated with the Paper Coalition on that, and we actually sat down and engaged the Food and Drug Administration in a conversation. They are a very forward-thinking agency, very receptive to patient input and patient engagement. And again, they can lower the prescription. So, they can lower the medication that's available over the counter, but then you get patients going to other medications that'll be easier for them to obtain, which is going to have a more negative effect on their health. Certainly with people in the whole transplant. And generally, I'm not a doctor, but some of the medications, I understand the commercials, they're just not good for you. And particularly when you take them in some type of volume. My daughter walks around, she's 19, with a bottle of Advil. She don't know I'm gonna snatch that bottle from her. Won't take her to the store. But back to your point is that we advocate, we spend a lot of times talking with the agencies. Remember, say, for example, the Kidney Health Initiative, where you have the FDA, you have a private sector, all the pharmaceutical companies, and then you have, my colleagues over the different universities doing all the research. So it's a constant dialogue that we have to have, but we think that we've gotten them to the point where when they have some questions, they will engage us as patients in the conversations. So one of our strategies is to educate patients.
So just to close out the session, Dr. Kaufman and others, as you said, it's your job to figure out what people are doing, not necessarily why they're doing it, but how to fix it. But that's what these people are interested in doing that are in this room. So final thoughts from our panelists on this issue of health literacy, acetaminophen awareness or lack thereof, that wait a minute, it may be in these different products. I don't realize that I could be taking X or Y or Z or have these different pain medications. What do they mean? What are some critical things the folks in this room can do at all as far as addressing the knowledge surrounding pain reliever safe use and selection?
I guess I'll just set the stage because I can't suggest solutions, but I think what we've shown is it really does matter. It really is an issue. People don't know, and they're misusing products because they don't know what they're taking. So it's very important, and the question is, what can you do to raise the level of knowledge in the population? I think it's a real challenge.
Well, I would say, and maybe it's unfortunate, maybe it's just the reality. It's one person at a time, one patient at a time. But enabling and equipping that one person, that one patient, who can also pass forward under their roof to their family and their loved ones as well. And that is, if you don't know, ask. If you don't know what to ask, there are questions that are already prepared that can set up that dialogue about safe and appropriate medicine use. It's not easy, and it's one-to-one, I think, really, very much.
And one of the areas that I would like to emphasize is the importance of working with community-based organizations and the role that it can play, especially when you want to raise awareness about issues of OTC and prescription medicine. So, and again, I'll mention the work with the promotoras de salud. They are key in the communities because people trust them already, and they already have the cultural proficiency where they can be more effective.
Yeah, I agree with everything my colleagues have said. And again, I would just emphasize, educate, and quite frankly, do not be afraid to ask your doctors questions. As my first doctor told me, Richard, I understand you're a problem patient. I said, why, thank you. He said, that wasn't meant as a compliment. I said, no, you were told that I asked questions, and I will continue to ask the questions. So feel comfortable in doing that. A lot of people are hesitant to do that. But remember, they're there to help you. So if you're not satisfied with the answers, persist, and you may have to look at some other options.
Thank you, everyone, for being engaged with us on this very important topic, and I hope you enjoy the rest of the